Major funding for Carolina Business Review is provided by Grant Thornton, an international accounting, tax, and business advisory organization dedicated to serving middle-market companies. Grant Thornton, a passion for the business of accounting. Novant Health, including Presbyterian in Charlotte and Forsyth in Winston-Salem, are affiliate heart hospitals of the Cleveland Clinic, consistently ranked #1 in the nation for heart care. Blue Cross and Blue Shield of South Carolina, proudly serving South Carolinians since 1946. And by Sonoco, a global manufacturer of consumer and industrial packaging products and provider of packaging services with more than 300 operations in 35 countries.
Well, now what? The highest court in this land has had the last word on the issue of Obamacare. They say it is not unconstitutional. So, do we get down to the business of assimilating this very complex and far-reaching legislation? Well, it would certainly seem that is the next step. I'm Chris William, and this is the most widely watched source for Carolina business and public policy. Can and will healthcare providers, insurers, and consumers now move forward and begin to embrace the health system's new reality? And what are key insiders saying about the next steps? South Carolina Health and Human Services Director Tony Keck, Carolina Healthcare System boss Michael Tarwater, and North Carolina Medical Society Chief Robert Seligson wade into the issues next.
Major funding also by the Duke Endowment, a private foundation in Charlotte enriching communities in the Carolinas through higher education, healthcare, rural churches, and children's services. And by Blue Cross and Blue Shield of North Carolina. Who's responsible for rising healthcare costs? Join Blue Cross and Blue Shield of North Carolina and many others in a candid discussion at letstalkcost.com. This edition of Carolina Business Review was recorded July 20th, 2012. On this week's program, Tony Keck, Director of the South Carolina Department of Health and Human Services, Bob Seligson, CEO of the North Carolina Medical Society, and Michael Tarwater, CEO of Carolina's Healthcare System. Now, Chris William.
Hello, welcome to our program. As always, all the good conversation happens right before the cameras and the lights come up, and usually right after. But gentlemen, welcome to the program. Michael, nice to see you. I'm going to start with you. So, Michael, what changes now? SCOTUS made this decision. Are the floodgates open? Is everybody breathing easier, or are we pretty much where we were before?
Well, I think the one thing that did not happen is significant, and that is the law did not get struck down. So not much changes. They did, as you know, rule that that the federal government could not coerce the states into Medicaid expansion, which was part of the plan. So the states are now going through various decision-making processes to decide whether they're going to play in that part of the game or not. Some have already decided, others are still looking at it. From a provider standpoint, really nothing's changed. I think from an insurer standpoint, really nothing's changed. And so, in your lead-in, in your opening comments, you said it's the final word. I'm not sure it's the final word. There's still a lot to be decided. The law was replete with references to the Secretary shall decide. And a lot of those decisions are yet to be made. But everybody should still be moving forward. Everybody should still be thinking about the implementation of the law. And the states just have a different decision to make now than they did before, maybe options they didn't have before.
So, Tony, that obviously brings you into this dialogue. What happens to Medicaid, especially since that is a big piece of what not just your purview, but some of those in South Carolina that rely solely on that. What happens? How do you manage it? How do you look at this, and how do you plan?
Well, I think that the decision that states are going through now actually is a decision. Before they really didn't have any say in the matter, and so it was easy to take a position one way or the other because you didn't have to vote on it. And I think if you look at every state in the nation, whether it's red state or blue state, legislators are going to debate this issue, and I think that's proper because every state's different. And what might work up in Massachusetts isn't necessarily going to work in South Carolina or North Carolina. So we've been very clear that we don't think that we should be expanding a broken program as the Affordable Care Act would suggest, and that we need much more flexibility, and we need to do it in a way that we can pay for it. And I think every state's going to have that debate. We're certainly going to have it during our legislative session. So we're looking to make our contribution, make sure everybody has the right numbers, and going to be supportive from there on.
Bob, the Supreme Court decision, how do you look at it now? In what direction? You have clarity, you have ambiguity, are we right back kind of where we were?
I think it's a mixture of all three. And I think that certainly we have an obligation to make the healthcare system better. A lot of times people talk about our healthcare system being inefficient or not as good as other healthcare systems in other countries, but I really think we have the greatest healthcare system in the world. We just have to learn how to provide care in a more efficient and quality manner. We've got to do a better job of providing that care. So the legislation, regardless of what happens, there's still change going on. There's transformation in North Carolina of our healthcare system in all aspects of the delivery. And so regardless of what happens in Congress or even in our own state legislature, there's going to be constant changing and evolving to try to provide more efficient healthcare services.
Is this just the beginning of the public policy debate now that we're past the Supreme Court decision?
I don't think so. I mean, I think fundamentally, the reason for a lot of the debate that's going on now is that the country can't afford health care on the trajectory that it was on. You know, the act itself that was passed in 2010 really was aimed more at getting uninsured people covered than it was at reforming the healthcare delivery system, to Bob's points. Work was going on in terms of healthcare delivery reform before the act. Work's been going on since the act through all this debate, and it needs to continue to go on, and it will. The act itself was really aimed mostly at some insurance reform, but really providing coverage for those that live in this country that didn't have it.
So Michael, let's stay with you for a second. So how does it change? You know, indigent care is a critical number at a hospital system like Carolina's healthcare system. So how does that change that number, which is a fairly large number that you deal with already? Does it get bigger? Does it get more expensive? And what happens to those folks whose first line of defense for health care was the ER? How does all that change?
Yeah, that first line of defense being the ER really varies from community to community. And in some places it's the only line. In some places it's maybe third or fourth in line, where indigent citizens actually have access to a physician whose name and face they know, just like you and I should. If you don't, you need to. So I think for us, the act contemplated providers giving up, in terms of hospital providers across the country, about $155 billion in payment cuts, primarily out of Medicare and also Medicaid, that would go toward paying for the people that are not insured or didn't have any insurance. More money came from other parts of the healthcare industry, and then there's about $500 billion in new taxes that was supposed to pay for the other part. If all that worked, at the end of the day, you have coverage for 30 million Americans who don't have it today, and theoretically, hospitals who take care of indigents would be paid something instead of nothing for those patients who interface with the healthcare system.
Tony, among your contemporaries in other states, those that run similar agencies that you do, what's the dialogue now?
Well, we meet on a regular basis, and when Medicaid directors meet, we don't talk about Republican ideas or Democrat ideas. We talk about how do we run these agencies where in many states they're covering 15, 20, 25% of the population.
And I'm sorry to interrupt you, but do you get a sense that it's a true bipartisan effort here to figure out what is best now that we have this new health care direction?
Well, I think if you talk to Medicaid directors, they're focused on essentially running an insurance business for poor people. And so they take a view of it that is, again, separate from the idea of expansion. We're much more focused on, and I think we should be focused on, how do we get people healthy? The goal of any health reform should not, the ultimate goal should not be to get more people health insurance, should not be to get more people more health services. It should be to get more people healthy. And so if you take a look at it from that perspective, 80 to 90% of health is actually driven by income, education, personal choices. 10% of it is on healthcare services. But what's happened in the country is that we have started to put so much of every new dollar into healthcare services that, one, you're not able to invest in these other things that really drive health and keep people out of the hospital. But two, coverage itself has gotten less and less affordable. And so when I speak with Medicaid directors and when I work with Governor Haley on this issue, our strategy almost exclusively, and I think maybe providers might echo this, is controlling the cost of health care as a way to fix a lot of our problems, not necessarily expanding a broken system more quickly than we can pay for it.
So go ahead, Michael.
I would agree with that. I think the key is, if you look at the other countries around the world that Bob referenced that have better statistics in terms of their health care, their inputs are very different. I mean, American health care is very good at rescuing people from themselves. The rest of the world's healthier. And and prevention is absolutely key in terms of changing the mindset in this country. There's got to be personal responsibility. At the same time, the system itself needs to be reformed because we are aimed at fixing things once they're broken, instead of trying to keep them from becoming broken and trying to keep people from becoming sick or injured. And that's got to be a focus. The problem historically from a funding standpoint is the payback on prevention is very good, but it far exceeds an election cycle. And so it's very hard for a politician to say, we're going to invest billions of dollars over here, and oh, by the way, we're not going to see a payback on that until, I'm not eligible to run for president again or whatever it is. So it's a very, very difficult problem, but it's one that we have to tackle while we're making the system more efficient.
And that's part of the reason, Michael, I think you'll agree, is that community care in North Carolina, where it drives the patients, Medicaid patients, into the system, where they have a patient-centered medical home to get them into the system early and get them before they've acquired acute illnesses. And clearly, healthcare is never going to get cheaper, and there's not more money coming to the federal level or the state level to provide for these services. So we've got to learn how to provide these services in a more efficient manner. And another area of the bill that really did not address the cost of healthcare when they started talking about, which to Michael's point about the political aspect of it, is the end-of-life issues. I can tell you.
What do you mean by that?
Well, I'll give you a personal example. My mother passed away 4 years ago. She was 84 years old, very independent woman. One thing that she had told my sister and I all through her life was, when I get to a point I can't take care of myself, I don't want to live longer. If I can't fulfill my own responsibilities, I don't want you taking care of me, I'm ready to go. And so we had the talk like it was just, and then she had a stroke. And I get this call in the middle of the day and fly down there, and the doctor says, your mom is 95% paralyzed. She probably will never, if she recovers, she'll require 24-hour, 7-day-a-week care. She's brain dead for all practical purposes. And we knew at that time that we didn't want to prolong that agony of what she would be living through. And so, we asked them to pull the respirator. And that was a difficult decision for us, but that's what my mother wanted. And this is a decision that Americans have to talk about now when their family's healthy, so that when the decision comes, or time comes, when a serious situation like this arises, that you know the right decision to make. And the end-of-life care is astronomically expensive and is really hurting the system, along with a lot of other things of care of healthy lifestyles.
How do you, I guess this is the question, but how do you deny that? End-of-life care is very expensive.
It is.
But is it a right?
Unfortunately, most people don't talk about it in advance. you know, one of the things that was talked about when this bill was being tossed around before it was passed in March of 2010 was, you know, the requirement that physicians talk to all their patients about end of life. You know, what do you want to do? And educate them, or try to educate them. There was a debate as to whether or not that would be paid for, you know, if the doctor took that time to do that. It is a very real driver of costs, and it doesn't always turn out the way it did in Bob's family's case. And so there are a lot of people in an ICU with their family telling the physicians, you know, you gotta do everything you can for Aunt Sally or whoever it is.
At all costs, literally.
And it is, you know, wide open. Politically, when the industry had that discussion with the folks who were debating this, the politicians and the administration, it was a very hard thing for them to wrap their hands around. It's hard to score. And if you can't score it, you don't include it. But there is a ton of resource being used there. And we're not talking about, quote, death panels. We're talking about situations like Bob described where it's really not just end-of-life care, but it's futile end-of-life care, futile.
And it's not a question, I think, of denying care. It's a question of planning for end-of-life issues, and the point made is that not enough people talk about this. We work with a lot of advocates in South Carolina, and AARP has gotten into the habit of starting every meeting when we're around the table in a large group, asking everybody who raise their hand who wants to end their life in a nursing home. Well, nobody raises their hand. And yet, we don't plan for those issues. We don't communicate our wishes to our families about how we want to live out the last years or the last days of our lives. And so what happens is you get a lot of miscommunication and a lot of emotion that ends up translating into a lot of cost, when in reality, I think most people you know, have a certain plan for how they'd like to spend those last few days. So it's really about, and we've told doctors this, because when an insurer has these conversations, it falls into the death panel conversation. But when doctors are able to talk to their patients and their families about it, it's a much different conversation. And in Louisiana, very conservative Louisiana with a very strong Catholic presence, we had a terrific dialogue about end-of-life issues, and actually the Catholic health systems there led the conversation about helping citizens of Louisiana make better choices at the end of life.
So, go ahead.
I was going to just add, going back to the issue of overall rising cost of health care, and acting on Tony and Michael's comments. Clearly, I think the citizenry of our state, of our country, have a real responsibility to take better care of themselves. And I think we've got to go through a cultural change. Instead of saying, well, we'll fix everything because you've not taken care of yourself, we will fix things that you couldn't control through no fault of your own. And so I think that the society as a whole has to embrace the reality that you have individual and family responsibility to say we have an obligation to take care of our bodies, take better care of ourselves, eating right, exercising right. I put a gym in the middle of my building. I have 40 people in my office, and they go up there and they work out in the middle of the day, and sometimes at the end of the day they've worked out and they still got a couple hours of work, and they come down and they're still in their workout clothes. But I'm okay with that. It's the culture of the office, because I know they're taking care of themselves. I've had people lose anywhere from 50 to 100 pounds on my staff because they've started taking more responsibility, and obviously it makes them healthier, happier, and a better employee. So, you know, the cost of health care, regardless of how much we do it as physicians or as hospitals do in changing the system, until we as individual citizens take on a more responsible role and take care of ourselves, that's when the cost of health care will start coming down.
Well, and Bob, I would make the case here to some degree that you're right you're in the bullseye of the industry. So you know, it's easy for you to lean into that. But and this is a one-off, and it's kind of a frivolous thing. But Mayor Bloomberg a few weeks ago made the point that they're basically going to outlaw large drinks, large cola drinks, or large carbonated drinks in New York. We've all heard it. So if we're not going to take responsibility for our health, does it need to be imposed on us?
Well, I don't think we're going to be outlawing barbecue in North or South Carolina, but it's Look, people have a right to eat what they want. They have a right to smoke. Right. But as the old phrase went, your right to throw a punch, it ends at the tip of my nose. And I think if you talk to employers, what employers are increasingly doing is that people have to understand that they have to pay for the consequences of their lifestyle. And so employers are starting to implement pretty serious penalties, in some cases incentives, for folks who smoke, for people who have a certain body mass index. There's companies around the country that won't hire smokers, and increasingly there's companies around the country that won't hire people who are obese because it sends up their health care cost. I was talking with folks at a large company that had recently located to South Carolina, and they were amazed at how much higher their health care expenses were of their new workforce because of health problems. And the governor is very interested in this problem because she considers it an economic threat to the state as an ability to attract companies if we're going to have higher than normal health care costs because people aren't taking care of themselves.
Mm-hmm. And food companies are recognizing this too. I think they're starting to jump on and providing more healthier foods. Even McDonald's, I know they do millions of dollars of research of looking down the road at what's coming down the pike. And you look at their menu, they're actually putting some decent things on there, oatmeal and grilled chicken and things like that. So there's, you know, the industry is starting to recognize that we better start offering some alternatives to some of the unhealthy foods we've been serving over the years. So I think that's, you know, at least the industry is starting to take hold of it.
So Michael, have you been, as an employer, forget about the whole healthcare provider thing that you do.
I'll try.
But as an employer, have you been able to move the needle?
We have.
I mean, pretty meaningfully,
yes,
when it comes to incenting your employees,
yes,
to take care of themselves.
Well, it's just, I said earlier, you know, prevention has a long lead time, but it pays big dividends. If you spend $1 on prevention, it's going to pay dividends down the road. We started a program a little less than 10 years ago called Live Well Carolinas. And we started inside our company because we wanted to eventually take this out to business and industry around the community and around the state, and then the 2 states, and expand it. And but we wanted to prove that it worked first. So we have a pretty large employee group. So we started with them, and we started doing health risk assessments and measuring body mass index and providing incentives for people to change their behaviors. Charging them, actually giving them a rebate on their health insurance if they would go through certain steps, like have a physical every year, know their numbers, meaning their cholesterol, their blood pressure, et cetera. And
so it wasn't punitive, it was incentivized.
There was a reward, right.
Okay.
And it changed lives. And I think it's changed the culture. We painted up stairwells and made them a little brighter and put pictures on the wall so that people would take the stairs. We've put in walking courses around our campuses, and you know, we take people who have never done anything like this and have sort of a little boot camp for them, and we get them started and we get them into it. We'll even pay for them to have a limited membership, time-wise limited, to the YMCA's in this market, and we do different things in different markets, but. And it works.
Well, we got a minute left, and it just very quickly. Bob, now on the other side of the Supreme Court decision, are you encouraged that there will be, that health care in this country, from a cost perspective, from a management perspective, from just a delivery and an outcome, is it going in a better direction?
I'm not going to base that on the Supreme Court decision. I'm going to base it on the fact that
we're past that.
That we're past that. I think that physicians and hospitals and the folks in the healthcare system have to work closer together to make it a better system. It's our responsibility. It can't be legislated, and so I think it's our responsibility to work across the lines where in the past, even with insurance companies, we have to work together to come up with better ways in which to provide health care. And then, you know, the doctors are working on, you know, in strengthening meaningful use and providing more cost-efficient health care. And I think North Carolina is the 3rd in the country in being certified in meaningful use. So.
Okay, about 10 seconds. Tony, as an institutional manager, are you encouraged?
I think the magic is happening at the physician level, at the health system level. The Affordable Care Act subsidies don't decrease the cost of care, they increase it, but the change is happening regardless.
Thank you, and I know we had to shoehorn these comments in pretty quickly. Thank you for being on the program. Michael, good to see you again.
Good to see you.
Tony, welcome.
Thank you for the invitation.
Bob, thank you.
Thank you for having me.
And thank you for watching. Hope your weekend is good and your health, too. Until next week, good night.
Major funding for Carolina Business Review was provided by the Duke Endowment, a private foundation in Charlotte enriching communities in the Carolinas through higher education, healthcare, rural churches, and children's services. Blue Cross and Blue Shield of North Carolina. Who's responsible for rising healthcare costs? Join Blue Cross and Blue Shield of North Carolina and many others in a candid discussion at letstalkcost.com. Grant Thornton, an international accounting, tax, and business advisory organization dedicated to serving middle-market companies. Grant Thornton, a passion for the business of accounting. Novant Health, including Presbyterian in Charlotte and Forsyth in Winston-Salem, are affiliate heart hospitals of the Cleveland Clinic, consistently ranked #1 in the nation for heart care. Blue Cross and Blue Shield of South Carolina, proudly serving South Carolinians since 1946. Sunoco, a global manufacturer of consumer and industrial packaging products and provider of packaging services with more than 300 operations in 35 countries. And by viewers like you. Thank you. Promotional consideration provided by Business North Carolina Magazine. For more information, visit carolinabusinessreview.com.